Hello and good afternoon, everybody. Thanks so much for being here on today's episode of The Care Plan. I am here once again with my wonderful co-host, Dr. David Casseret, and our lovely guest today, Gina Upchurch from Senior Pharmacist. Gina, how are you doing today?
Doing great. Thank you. And thanks so much to you both for having me.
Oh, well, thank you
Thanks for
being
joining
here.
us.
We've both Dr. Sieg and I have been looking forward to this episode for weeks now, so we're really, really grateful that the day is here. But you all already know we're going to go ahead and just kick it right off with our lightning round. So, Gina, if you could only save one medication from being discontinued forever, what would that medication be?
I think most people would assume I'm going to say the GLP-1s, but we don't know enough about them. So I will say the salicylates or aspirin. It's been around for a long time. We know a lot about it. Prevents heart attacks and strokes. So I would say the old-timey, very inexpensive salicylates.
All right. We love the little baby aspirin in the mornings.
That's right.
So you're trapped in an elevator with a congressperson for 20 seconds. What's your Medicare pitch?
My Medicare pitch is that it's cruel and unusual punishment to make older adults and adults with disabilities every year go through the scramble of deciding their health insurance coverage, and that we need more standardization. As a participant said to me once, I don't understand all the details. I just want it to work for me. So more standardization of Medicare.
Absolutely. Yeah, I mean, like the knowledge gaps are, I feel like, where people get to benefit when people don't really know what they're signing up for, but I'm sure we'll get into that.
Yeah.
So if you could uninvent one medication,
Yeah, that's a hard one. I think I've landed on Vioxx, or the brand name. It's not on the market anymore, even though there is some effort to bring it back. Rofecoxib. It was the generic name. It was on the market for 5 years. It was supposed to have less GI bleeding, but help with inflammation. It's very similar to celecoxib in many ways, but the company knew for quite a number of years that people were having more heart attacks when they were taking it and strokes. So they estimate that at least 50,000 Americans died during that 5-year period related to that medication.
Wow.
But it's complicated. So it's off the market as an oral medication. But the good news about it, I mean, just devastating, obviously, for those families. And many more people were injured from this drug. And the company knew about it. And so there have been lots of lawsuits. But the good news about it is that it's led the FDA to be more serious about regulating drug safety and doing more post-marketing surveillance. And it used to be that the FDA would just say the drug's approved or not approved. And now there's this sort of
continual vetting.
Yes, continual vetting of the medicines and continual reporting. It's not been great. Post-marketing surveillance, sometimes the companies never come back with the follow-up studies or follow-on studies. So that's a real big concern. But ideally, we want to gather more data before we unleash drugs on the public, because they all assume that the FDA has made sure that it's super safe before you take it, and that's not the case.
Absolutely. We're less than 5 minutes in, and I feel like I'm already learning so much. I'm just out of curiosity, like, when was that? Was that like within the last decade, or was that?
No, so I think the drug came on the market in 1999 and came off on 2004, but it is being discussed as a topical for specific pain that's related to people who have hemophilia. So, again, medications are complicated, right? And how you use them and the dosages. But that huge debacle has led, obviously lots of death, but more importantly, or not more importantly, but also has led to some safety regulations that are now in place.
Well, thank you for sharing that. I mean, it's definitely certainly good to know. But love that maybe for some precedent is being set at the very least, that is allowing for us to move in the positive direction. My last one is, what's a drug interaction that scares you, but most people may not really know about or talk about?
Yeah. This was sort of hard for me because a lot of times people think of, drug interactions being a big deal with what we deal with as pharmacists or health educators, and it is. But we often will see duplicate therapy or drug disease interactions, not so much drug, but one that immediately comes to mind with older adults is that you have these individuals taking medicines that are supposed to help with memory disorders, and they're supposed to build up acetylcholine. But at the same time, a lot of people take anticholinergics or antihistamines, things like Benadryl, Zyrtec, sertraline, all of these. I'm not sertraline, cetirizine. There's lots of medicines that are supposed to help with your allergies or and some rashes and that kind of thing that actually lower acetylcholine. So you have people often taking both drugs at the same time, not understanding that one's increasing acetylcholine while the other one is decreasing it.
Wow.
Yeah.
You should teach a class on this stuff. I could listen to you talk for hours, honestly.
I do teach some classes.
She does.
But not on drug interactions. Thank goodness. We let the more clinical pharmacists do that. I play one on TV, Mandy.
Well, that's great. So I kind of want to just go back to the beginning. You're in Smithfield, North Carolina, and maybe sitting in your grandfather's lap, counting some pills, and maybe fast forward a few years to watching your grandmother unfortunately suffer from some of these medication side effects, and in a nursing home. So how did those two experiences kind of shape what you've built here at Senior Pharmacist? Maybe tell the audience a little bit more about what it is that you have built.
Yeah, I grew up in the small town of Reedsville, North Carolina. My father was from Smithfield. His father was a pharmacist. That's why I was counting pills in his lap. So I would go in the summers and help him, or mainly work at the ice cream counter. But he was very wise counsel to a lot of people back in the day, and people trusted him. He was a trusted messenger back in the day as a pharmacist. So I had held him in high esteem. Then that's my dad's dad. And then my mom's mom on the other side, years later, I was just starting pharmacy school, and my grandmother was in a skilled nursing facility taking a medicine that's haloperidol, which some of you may know. And it was causing her to have side effects that looked like Parkinson's disease. So she was diagnosed with Parkinson's disease. They were starting to add on other drugs. And one of our very first participants had the same thing. So I knew that some of these problems that she was having were coming from the medicines that they were giving her. So it's that combination. And frankly, I've not had these aha moments. It's just been my life lessons of seeing him admired and seeing her over medicated. He was helping people access medicine. She was, needing to avoid some medicines. And it's really that combination. It has been a big part of what Senior Pharmacist has become.
Wow. And I really do love these moments where, like your pharmacist kind of is like a part of your community, especially in smaller towns and things like that. And, I'm like thinking of like to maybe like some of the older movies that I've seen where there's like usually like a, what's it called? Like a soda counter or like an ice cream station or something like that at the pharmacist. So it really does like add to that part of the experience and things like that. And I know that, my family has been with the same pharmacist since I was like maybe 10 or 11 years old. And to this day, every single time, if any one of us goes in, my dad actually had a heart attack a year and a half ago. And every single time one of us, it's whether it's me, my mom, or my dad, the first question is, how's your dad? Like, is he taking his medication on time? Like, how is this doing? And is he making sure to do this? And it's just like the little things that really, really matter. And the community that you build around that is
right.
So.
And I have major concerns about the viability of community pharmacists now because of the way that we're going all mail order. These recent announcement about a website maybe in 2026 we order directly from the manufacturer. I mean, you can imagine older adults getting drugs from all sorts of different sources. And this is bypassing the pharmacist. We're doing that because we wanted to bypass the pharmacy benefits manager because they've been put in the middle and made a lot of money off of it. But bypassing the pharmacy, I think it's just a huge oversight. And pharmacy benefits managers do play a role. That's not all bad. We just need to keep a check on it. And it needs to be more transparent. But I have major concerns. The pharmacy benefits managers have really, and the insurance companies have really made it difficult for the survival of independent pharmacies that we know during COVID were so critical to people getting shots quickly in their arms. Even now with flu shots and the COVID shots now are a really critical part of our public health force too.
1,000%. Thank you for continuing to advocate in this community.
Absolutely.
Great. Let me jump in with a kind of related question that you started to touch on it with the last question, but you didn't quite get there. So I'm going to push you a little bit. I mean, most pharmacists go to work for CVS or Walgreens or whatever, but you took a really different path. When you were a grad student, you decided to start this nonprofit. So was there like a single aha moment that made you convinced that Pharmacist was necessary? Or is it kind of gradual, or how did that happen?
Right. Thanks. No, there were things that led me to that. It wasn't aha. It was my life story because I was in the Peace Corps. Actually, I went to pharmacy school, worked at UNC hospitals briefly, inpatient. Then was in the Peace Corps and learned the value of community development.
Where were you?
Botswana.
Oh, I love
I've gone back
Botswana. Yeah, I spent a lot of time there in Gaborone and North. Yeah, I didn't know that.
So I go back. I'll be going back in February, I hope. But I've been back about 12 times and have all sorts of things going on. I'm Granny G when I'm there. So, yeah. So, but what I learned there was that if something's going to be sustained in a community and be helpful to that community, it really needs to be identified and owned by that community. And I just brought that back here, had gone to pharmacy school, did a residency in geriatrics where I saw people being over medicated, couldn't afford it, decided to go to public health school, needed a summer project, called the local senior center, and they were working with the hospital to see what could be done to help low-income older adults who couldn't afford their medicines in Durham. So I was like, perfect. But I knew that if it was going to work, that the people in Durham had to decide how it was going to work. So I just started interviewing people about the issues, and that is really how Senior Pharmacist was born. So I didn't think it up out of it was told to me, shall we say.
True community, like at its core. That's amazing. And that's the best way to build something, actually. We are building something here at CareYaya ourselves too. And we found that no matter how much we look things up on our computers and how much we talk to each other, really the people that are going to be able to give us the answers are the people that need our solution.
That's right.
I love that. That's
right. Exactly. And that is the driving force that has kept Senior Pharmacists going and, quite frankly, morphing at times. So at one point we added tailored community referral. Well, I'm going to tell you everything you're eligible for, but if people are medication insecure, they're often food insecure or have health. So we end up learning about food options for people. Not that we do them, but we have connections. We like to say the better we are integrated to other agencies, the less navigation the individual has to take. So we really try to work hard. And that's why we appreciate CareYaya as an option for people that need help in the home. Yeah.
Well, we appreciate you guys. Thank you. That just warmed my little heart. I need to take a second. So Gina, maybe try and paint us a picture. I'm kind of shifting gears here to now in 2025. What does medication insecurity look like? And who's walking through your doors, and what are they really struggling with?
Right. So that's a great question. Actually, I'm looking at our annual report right here just to describe who receives our financial assistance. So Senior Pharmacist gives people a card, very much like a credit card, that they can take to a pharmacy and bill medicines to shrink their copayment. So the people that are eligible for that, their average age last year was 75.
Okay.
44% of them live alone.
Oh, wow.
70% are female. The average single income was $2,200, and the average couple income was $3,300.
Wow.
And I don't know if you know this, but more and more people that have Medicare are having to spend a larger and larger percent of their Social Security on healthcare, on their co-payments, on their co-insurance, on the other things they need that Medicare does not cover. So these are the people that we are mainly focused on with our financial assistance and our med management. Most of them in Durham are African American that need that help, just because the historical trends of advantage and disadvantage through the years by the social construct of race.
Yeah.
But they're all over the place in terms of race and ethnicity. We do our Medicare counseling. We call Medicare the equal opportunity confuser. So whether you're super wealthy or you're any age, because you can have Medicare due to age, permanent disability, end-stage renal disease, or Lou Gehrig's ALS. So we help all of those people with Medicare counseling. And so that really does run the gamut. It could be anyone that needs help with Medicare.
I honestly, can I call you Grandma G too?
Granny G. Granny G.
Granny G.
It's so sorry. But that's fabulous. I mean, just the way that you think about these issues, and I can see how much effort and energy and time you've put into it, and It's really beautiful. Thank you.
Well, thank you. And I'm just going to say the reason I can do that is because I surround myself with brilliant people. When I say that, brilliant in the sense that they're smart, but also brilliant in the sense that they're passionate about the work that we're doing. So the team at Senior Pharmacists, our board, our committees, just really wise counsel for many years have led to this agency. Teamwork definitely makes this dream work. That has to be. Yeah.
Great. Could I go off script a little bit? I'm taking care of a patient now who is on MS Cotton, which is either a twice a day or sometimes in some people, maybe 10% of the time, a 3-time-a-day drug. But he's just taking it once a day. And I asked him why, and he said he didn't have enough money to afford it, so he's trying to make it last. So, he's taking a medication incorrectly because that's all he can afford. And, as I was walking down for this interview, I was thinking, like, what do you see? And are there other medications that people sort of ration or scrape by or maybe take inadequately, inappropriately, ineffectively because that's all they can afford?
All the time. Yeah, absolutely. Especially when we first meet them. Now, hopefully with our help, we can navigate all of that, whether it's therapeutic substitution, generic substitution on the plan that they're on, if they have Medicare, patient assistance programs, RX outreach, discounted generics, cost plus drugs. I mean, there are lots of options that we try to help navigate, but it's gotten super complex, but we absolutely see it. And, I like to say that adherence is a means to an end, not the end. So just because you're adherent doesn't mean you're better. In fact, we're concerned about polypharmacy, the multiple use, sometimes unnecessary, not always unnecessary. I have a friend with AIDS who reminds me that polypharmacy can be a grand thing, right? So it's not always bad, but for more frail older adults, the more meds you add, the more risk people have from those medications. So what we try to do is help navigate that and help people access what they need, because it is a huge challenge. I mean, everybody knows here that we spend 2 to 3 times as much as other countries on medications.
Wow.
Is the list price anyway, not necessarily the net, but the list price. The problem is, and that's a huge problem. But what we often don't say in terms of health, we spend about half as much on social care, housing, food, that kind of thing. But yes, medication non-adherence is big, and we find for the people we see, it's mostly cost. Sometimes, I mean, it's very intentional non-adherence. Well, I had to ration. I couldn't afford it. Or the other thing that we see often is that when I take that, it burns my stomach. Well, have you talked to your provider about that? So we sometimes are the ones that encourage people to speak up, speak their truth to their provider about their medicines.
I love it. Kind of maybe some practical advice that you could offer to our audience at home. So we all know that open enrollment is coming up. So what's the single biggest mistake that you see Medicare beneficiaries make when they're choosing their plans, and maybe how to avoid that?
Right. Great question. So the biggest mistake is they don't get help to do it. So 70% of people don't get any sort of assistance to navigate the plans every year. Every year, not only can the plans change, the medicines they cover, the doctors they're in network, depending on whether you're talking about a standalone drug plan or Medicare Advantage plan, things can change dramatically. So seniors health insurance information programs are all across the country. Some are better than others, but they offer unbiased assistance. The vast majority, only 30% of people get help in any year. The vast majority are relying on agents and brokers. And they are often selling certain products. Now, that's not bad, but they may not give you the entire plethora of options that are out there. So people just need to be aware of that. And agents and brokers traditionally have made a lot more money selling Medicare Advantage plans than they have traditional Medicare with the supplement, the Part D plan. That's getting exposed now to some degree, but just getting help to navigate, because it is too complex. And there are local people that can help. There's a 1-800 Medicare number. There's a state SHIP office, usually in most states.
It's all available to folks for free?
Yes, all the SHIP program you don't charge anything for. It's not free because we have people doing it, because we have to raise money to do it. But absolutely, it is no charge. The other thing I would just say is that when people, get that help, it's important to support those agencies and programs that are, are out there helping with that navigation. And we'll see. There's been threats to funding cuts, certainly at the federal level and now at the state level. Federal it's as far as we know is flat. We're worried about our state's support of the SHIP program this year. So TBD.
When is it,
That's a great question. When we have a state budget, we'll know when we have a state budget. And of course, we have this hold up with our federal government now. So, a lot of things are not known right now. The other thing I would just say to people who are sorting through their Medicare options is that people tend to think of the here and now. And in certain states, including North Carolina, and there are only 4 states where if you're in a Medicare Advantage plan, you can automatically go back to traditional Medicare and get a supplement without underwriting. States like North Carolina, if you try to get back to the other side to a traditional Medicare, so there's traditional Medicare and all-in-one managed care Medicare Advantage. Nothing's right or wrong about either of these. They're just different. Okay. So if you go to Medicare Advantage and try to get back to traditional Medicare and buy a Medigap, in certain states you'll have underwriting when they ask medical questions and can really jack up your rates. So a lot of people don't know that. And so they get a Medicare Advantage because they like all the perks, and they often have very good drug benefits, and it has hearing, dental, vision, things that Medicare should cover, but they don't. So there are these things that are here. But when they get really sick and they have all this pay as you go, this much to see a specialist, this much every day in the hospital, this much for rehab, and they go, oops, I want to get back over there and pay a larger monthly premium and not have all this pay as I go thing. In certain states, you won't get back in an affordable way.
This literally
yeah. It's hard for people to grasp when you're young and healthy and 65 and you see all these additional things at less cost. It's very alluring.
Yeah, absolutely.
So could I ask a question about that, or at least tangential? This is kind of a political question, but we don't need to make it that. I think some of this conversation in the last 20 minutes has really been about what people don't know that they don't know. And in the current government shutdown, the Democrats have really decided to focus on healthcare. That's their issue instead of tariffs or maybe other things. So, without weighing in about politics, I'm just wondering whether you have any assessment of the Democrat strategy. They're relying on people being angry, worried about access to healthcare. On the other hand, lots of people don't really know if I'm hearing you right. They don't know what their risks are.
That's exactly right.
Was that a good strategy to focus on healthcare when it's not top of mind for a lot of people? It's top of mind for some people for sure, but does that make sense?
Right. Great question. So I think what's happening now, so the Medicare open enrollment period starts October 15th. The ACA open enrollment period doesn't start till November 1st, I believe, but people can start seeing the cost. We have all these different enrollment periods, so it's very confusing. So people are starting to see, and small businesses like senior pharmacists are starting to see premiums go through the roof. And the reason senior pharmacist worries about people on Medicaid that may be losing, Affordable Care Act plans that may be losing it, is because if they don't have coverage and they hit 65, they're going to be sicker. And they're going to cost a lot more money. They're not going to be as well. So we have, that sounds kind of selfish, but we do worry about that. And of course, we want them to have access to basic health care. And so we very much appreciate that somebody's standing up saying it's not okay for people that are struggling financially. And the Affordable Care Act did link it to people's income. And as we know, they expanded that a few years ago so that even more people got cost sharing reductions. But I know from some of my nephews that if those go away, they probably won't have health coverage. And that can be financial ruin for people. So, they're standing up for access to care. I don't know if it's going to work, but we feel strongly about it also.
Yeah, great. Thanks. And maybe a follow-up question that's related. You're on MedPAC, which is a huge deal for, hometown pharmacy girl. We send to Washington to represent us and the rest of the country, which is super cool to be even talking with you. I wonder if you could reflect a little bit on how that happened, how you got there, and if you're comfortable talking about it. I don't know how many of these discussions are closed door, but anything you could tell us about what you do with MedPAC or how you feel you're making a difference.
Thank you. And by the way, all the MedPAC meetings are open to the public. Everything we say is, on record. So that's a great question. The Comptroller General of Government Accountability Office is the one who makes the selections. I applied for 4 years. As I like to say in my interview process, as we all know, 4 times the charm, and nobody laughed. I was like, okay, people, I was being funny. I think, I definitely said I'm a consumer advocate. I am a pharmacist. I am a health educator, but I am very much a consumer advocate, and I'm very frustrated by how complicated the Medicare system is. Nobody in their right mind would have ever built Medicare to be what it is today. Nobody on the MedPAC. And by the way, I can never speak for the MedPAC. I'm just speaking as Gina Upchurch here.
Absolutely.
And, I think it's just been a patchwork. In 1965, it was just a hospitalization benefit for older adults. Then they added, the paying for the physician and paying for outpatient. And then they added people with disabilities, and then end-stage renal, then Lou Gehrig's. So it's just been a patchwork, and all the different enrollment. They added Part D, not till 2006. They added a drug benefit. So it's all been patched together, and it is not streamlined, and it needs to be, because it's way too complicated. We call what we do, we call it decision-making paralysis that people have. And so what we do is choice architecture. How do you set up the choices that people have? And as they add more and more variables, it gets harder and harder to truly help people make informed choices, because we don't have a crystal ball what their health's going to look like the next year or the next 20 years for that matter. So again, I'll go back to our statement of what I think a lot of Medicare beneficiaries never had one beneficiary tell us we need more choice. They say we want more standardization. This is too much. My favorite quote was from a gentleman who said,
"Let's hear it.
Ma'am, I like all this choice. Choice is good." He said, "But I wanted to choose between paper and plastic, not all of us." And I was like, ooh, okay, perfect. He was a farmer. And I said, I agree with you. We need paper and plastic choice. Yeah.
There we go. That's, it's honestly, I feel like as technology continues to advance, and as, we continue to innovate and grow as a society, that decision paralysis is only going to get worse, because there's going to be more and more options. There's just there's abundance, which is, to be grateful for, but also at the same time, it can really kind of get in the way of things too. And it's getting in the way of me right now, because I don't know which question I want to ask you now, because there's so many questions that I would love to, but I guess maybe this is one of my favorite questions that I just generally like to ask. And that's my magic wand question. So I know that, there's so many things that are broken, and, if you could, you'd probably magic wand 10 different things, but if you could change one thing about Medicare policy tomorrow, what would it be and why?
Right. It would be to simplify Medicare, choice options for beneficiaries. Again, I think people they want it to work. As again, our participant said, I don't want to have to understand it. I just want it to work. So this, whether it's economies of scale, just somehow being able to have Medicare be in a position where it's not only getting good prices and good care for the beneficiary, the older adult that's paid into Medicare A all their life, they get B when they need it, the outpatient. But we paid partially, but Medicare is heavily subsidized by federal revenues of the government. So I think on some level, we need to be real careful with that funding. It cannot keep going. Healthcare is more than 17% of the GDP. Medicare is the largest part of that. If we're going to watch taxpayer dollars, we need to make sure we're getting what we pay for. And it's really sort of getting out of control. We're paying more in many ways than we need to be, because we've heavily privatized Medicare. And we're paying a lot more for it, and we're not getting the outcomes that we need. So focus on outcomes and standardization of the Medicare benefit.
It's really interesting to me to hear you talking about both cost containment and access. I think a lot of people in this debate are really focusing on one or the other.
Right.
But you're trying to balance both, which I agree with, but it's a tough balancing act.
I think it is a tough balancing act. There's a lot of anger at pro-authorization right now. Well, you do want pro-authorization on low value care, right? So it's not, and all of these things are sort of complicated. They're not easy to have little quick, comebacks to, because they are sort of complicated issues. But I think there is this balance of, we want to pay for things that bring the most value, and we want to lessen the payment for and I do think we move that way with sort of accountable care organizations with traditional Medicare, and then some Medicare Advantage plans, particularly that are driven by providers, and not the insurance companies that have shareholders. But when providers are driving the managed care, it often has better outcomes at lower cost. And, there might need to be a distinction between provider-led Medicare Advantage plans and those that are more commercially led, in terms of how we look at them and how we reimburse them.
Yeah, a lot of sense. And, I kind of want to maybe do a little bit of a follow-up question on that, just in general, because I know, technology is advancing, and there are different tools at our disposal, and with AI on the rise. I'm wondering, is there a use case for AI that you would see that would be able to assist pharmacists and educators right now in moving the needle on insurance knowledge and medication adherence, potentially even?
Yes, have an idea. This is y'all's job to figure this out.
All right, we're on it.
So we thought that electronic health records were going to make, med reconciliation better.
Mm-hmm.
We see med lists that come out of health systems, hospitals. This provider over here is using one med list, one EHR. This one's using another. We were supposed to have health information exchange that made it one, but people don't like sharing their data because data is money. I mean, it's gotten very complicated. We would like for the individual to own somehow their med list, because there are so many different sources of meds now, and it might get even worse. And it includes the prescription, over-the-counter, the herbal, senior pharmacist. This one's Spanish, but we have med records that we print out electronically. Who's your provider? What are adverse events? What are drug interactions? What are your meds? And over-the-counter. And we say, look, advocate for yourself.
Yeah.
If you're seeing a provider, say, do you know this is exactly what I'm doing here?
Mm.
If you want to add something, can you take something away? Can you reduce the dosage of anything? So really having consumers have that, whatever it is, some sort of way to say, this is always my updated list of medicines. We used to have the vial of life that would be in people's refrigerator. There have been all these public health efforts through the years, but I really think, and Dr. Rob Califf spoke at a fundraising breakfast we had recently. He was head of the FDA a couple times. He's a cardiologist at Duke, wonderful person.
Yeah, I know Rob.
Yeah, he spoke with us. And one of the things he said was he thought people understanding their medicines and knowing their medicines, and I would also know your insurance, that is critical to your own health. You have to advocate for yourself. So if there's any way electronically to pull in from all these places and to always have an updated list of your meds with you, that would
It's huge, because our nurses and pharmacists, when somebody's admitted to the hospital, spent a lot of time just figuring out what medications people are taking.
Right.
Now on our Epic screen, there's a list of home meds and hospital meds, and those never match. Not that they have to, but
right.
There's so much energy that's put into this that should be really straightforward.
That's right. We worked with some colleagues at Duke and published a paper about medication reconciliation. And one of the things that became evident from that was a lot of times the patients or participant, we call people participants that are in a program, but if they're patients and they're in a physician's office, a lot of times they may feel more comfortable talking to the medical assistant about, I don't really take that because it's kind of expensive. The provider's got plenty to do. They're so overwhelmed already. Are there other members of the team that should be trained and own that, and then that can then, sort of triage it up to a clinical pharmacist if it's really complex and you need to maybe go in their home or something, or to the provider and tee it up. But a lot of times, some of those people can't even make changes in the electronic health record. I mean, I bet most of your people listening to this will know you've tried several times to get your med list changed in the EHR and it didn't work.
Yeah.
Right? You came back and it was still there. Okay, so just being able to have people that are trusted to do that, and that somebody owns it. But I would love an electronic version.
Okay.
That made me think. Yeah, we just one thing you said made me think about this. We have a grant which hopefully is going to get funded. That's a collaboration between Duke and CareYaya for a platform called Goal Coach, which is an AI-powered way of engaging patients in goals of care conversations that flows to their electronic medical record. But one of the things we heard early on was it's kind of weird. You're talking to an avatar, but honestly, I'd rather talk about my goals with a machine than with my oncologist because, they're understanding, they don't push back, they don't argue, they don't tell me to keep fighting. So I wonder if, based on what you said about how people like to have these conversations, could we build an AI platform that would do that med rec telephonically or the phone? And then if there are discrepancies that are identified, that would bubble it up to a pharmacy or somebody else as a screener. We could do that.
We're about as low tech as you can get here. But what I like about what you just said, I think the key with that, if it were to work, would be the messenger that introduced it. Because what's happening right now is we're getting so many people who are like, I'm told, don't answer the phone, because they get 6 calls a day from somebody trying to sell them something that's sometimes real, sometimes not real, sometimes fake. Their mail, they don't have to open it up because they believe that it's rubbish, or their family members tell them not to open up. They see the stuff on TV, it seems too good to be true. We tell them it probably is. So they're getting isolated. So I think any intervention, any sort of successful thing that we do has to be introduced, and that needs to be connected to the individual by trusted people. So if they have CareYaya people helping them, just so that they know this is a valid thing. Like I'm not going to trust and participate until I know that it's real. So that's an interesting thought.
I mean, I think just quickly going back to your earlier point, I truly do think that like healthcare is like a team. That is how you get the best results, is when there is a pharmacist involved and a physician involved and a social worker involved and a nurse involved or a medical assistant. And it's like these people all have their own niches of expertise. And, Dr. Cass, right, you might have your 2 cents on this as well. But I feel like that is just, in that way you are able to best give the care, because you can't be a jack of all trades but master of none, right? So it's that's why it's so important to kind of like hyper focus and make sure that at the end of the day, like everyone has the same goal of making sure that you are the best version of yourself that you can possibly be. Right. And so it'll be nice to kind of maybe see that come to life in my lifetime.
There you go.
So if I could, let me shift gears a little bit. We have a fairly young audience. I mean, a lot of people listen to this podcast, but I think CareYaya has something like 50,000 undergrad students now who are engaged in caring for older adults around the country, and many of them listen in. So I'm always thinking about them. I'm going to retire at some point, and I'll be like a patient rather than a physician at that point. But they're all trying to figure out what they're going to do with their careers. And I'm reflecting that you've done a remarkable job of working out, boots on the ground, trying to figure out how to make the life better for the patient in front of you. And also seeing gaps and then doing something about those gaps with state and national policy changes. So I'm wondering what advice you would give to them, because they're going to go into healthcare professions and they're thinking idealistically of, all right, this problem comes up again and again as an intern or whatever. How do I take a couple steps back and a couple steps up and really, rather than just complaining about it, how do I start thinking about solutions? Any advice for the future of healthcare listening out there?
Right. Love that. So, I think people do best when they're in their flow, that term, their flow. So it's something, and I think you get into your flow when you're passionate about it and you know something about it, right? And so I think for some people, it would be a luxury. Some people, they can't do what they're passionate about. They have to make a living over here. And that's not the thing that they're passionate about. And so I just want to acknowledge that everybody can't have their flow be their career. But for me, I was fortunate enough to be able to, go to pharmacist school, then Peace Corps, then grad school, that led to this agency. And I have just learned day in and day out from people walking in these doors here, the barriers that they face and what makes facilitating their health better. Right? So I have just learned from being on the ground. So as much as you can put yourself on the ground to learn those things and develop that passion, then you speak with some authority. I mean, I go to these MedPAC meetings and so they said, you're the only one we've ever known to bring props, because I had all these cheat sheets for Medicare D, and we're in the middle of a meeting and I whip out these cheat sheets and they're like, we never had anybody bring props. And I was like, well, this is my life. This is how we help people. So just, I think lived experience and trying to be an authentic voice for those. Well, first of all, having the lived experience voices at the table, as much as you can push that and encourage that. But then also when you can be, and you have the privilege of being, that representation, to try to be as authentic as you can, people sort of get that's what's happening, and it adds a little bit of credibility to what you're doing.
That's so beautiful. That's great practical advice. And I appreciate you acknowledging sort of, sometimes you can't follow your passion either. But yeah, I guess maybe like it almost, I feel like maybe you had the opportunity to, and it was, and I'm really glad that it kind of like, it was the way that it was, because you have had such a great influence. So I guess my final question to you before I move into our audience questions is, what's kind of kept you going through the decades of burnout, funding struggles, bureaucracy? What gets you up in the mornings?
Yeah, besides really good coffee. Okay, there's you know what? It's without a doubt that I know we're making a difference. So, I mean, I literally, the receptionist desk is not far from me. So I will hear people leaving offices where they tell me, I just cannot thank you enough. This is means, I have less stress because your organization exists, and just our staff. I mean, if our staff, any of the staff that's here, when they've ever left, and we've had people that have been here a long time, but for those who've left, they'll always say the best part of working there, and all the people working here for sure say it, is that every day I know I'm making a difference in somebody's life. We're helping navigate. We're helping with very practical concerns that people have. And that's not often, I've been dealing with a couple of people where the customer service has been horrendous. I was trying to deal with some bookkeeping software people and the bank situation. And I'm like, you get these, nobody can answer your question. Nobody seems to have the authority to answer your question, but you come in here and you will leave with answers. Even if the answer is that resource you need does not exist in Durham. At least they don't keep doing the runaround looking for that thing that doesn't exist.
Absolutely.
So I think knowing that we can practically make a difference in people's lives, it just, that makes all the difference.
Gets you up in the mornings, and that good coffee too.
Definitely. Yeah.
That's a beautiful, beautiful answer. We do have some great questions here from our audience that I would love to present to you as well.
Okay.
So the first one is, I love this one. You mentioned you've surrounded yourself with good people, with a little smiley face. I'd love to hear about one of those people who have been some of the mentors or role models that have shaped your journey, and what impact did they have on you?
Yeah. Boy, I've had a lot. So I can think of 5 strong women. Five strong women that have been, and I think the reason, I'm just trying to think of the thread that goes through all 5 of those. I think they all would tell me to have my own voice, right? They wouldn't say hesitate, or you got to do things PC, or you got, that's a man's world. And I've never had any of that. It's just like, okay, just speak your truth. And they all didn't hesitate to tell me that, including my mother. So, I think it's just feeling free to be a leader and not feel constrained in that way.
And look where that's gotten you. I mean, it's great advice.
Sometimes some trouble, but okay. Yeah.
The good kind of trouble. I love it.
Yeah, good trouble.
We have another one. You kind of already did touch on this, but it like kind of takes like a different spin to it. And maybe you want to nail this answer down one more time. But if you were building a new tech solution, I know we kind of talked about that, to simplify their enrollment or review process, what would be the single nightmare scenario that you would prioritize solving?
Well, we talked about the electronic, list of meds. I think there's a lot of work that can be done with Medicare plans, especially the Medicare Advantage plans, because there's so many different variables. So just this example, dental, vision, and hearing. Could there be dental essential, dental, dental plus, dental? I mean, like we could streamline and make those things more readily available. We could ask people, what are your priorities? And then have it go into the algorithm and spit out, here are the top 5 plans for you. So I think there's a lot that could be done with navigating some of the variables in Medicare Advantage plans if people choose to go that route. Might be large language models that can read through all of the details of the summary of benefits. But the problem is, even with the summary of benefits, a lot of that stuff doesn't have the details. In other words, this is a reimbursement program versus you have to go to these providers to get it.
Mhm.
and you don't get reimbursed. You just go straight to these dentists versus you go to the dentist and get reimbursed. You sometimes can't even find that in writing. You have to call the insurance company to ask that question, and sometimes they'll only answer it after you've enrolled. So
Yeah.
there's some barriers to it, but I think there's a lot of ways that technology could help, simplify some of the Medicare Advantage choices.
Gina, I've never been more serious in my life. Let's hop on a call right after this and see what we can do together, because we can probably make some magic. And I got Neil, our CEO, over here messaging me saying, she's awesome. Let's look at it together. And I'm like, I'm doing a podcast. Let me focus on my podcast.
Yeah. I think
Back off,
there's
Neil.
always movement afoot around improving the Plan Finder tool, which is
Yeah.
the Medicare website that we use. But I think there's definitely,
There's
we're
more
starting down here. There's only one way to go, and that's up.
There you go. There you go. And then maybe one last quick question, if you want to just do like a lightning round version of it, because I know that we're running a little bit over, but is there transparency for consumers in open enrollment period about denial rates by insurers so that they can make more informed choices?
That's a great question.
That is
I
a
love
great
that one.
question. The answer is no. There's not even really good data for the MedPAC or anybody else around denial rates or authors. So we don't do a good job of collecting all of that very well. We're getting better at some of it, and I think there's some pressure now to do more of that, especially around pro-authorization and categorizing this. Again, pro-authorization that's decreasing the use of low-value care should be rewarded. Pro-authorization that's decreasing medically necessary care, or dinging a hospital after the fact, or saying it was observation versus inpatient after the fact, without real clear guidelines up front, needs to be stopped. So it's sort of a complicated issue, but we don't have great data, and I think we're trying to get more of it so that it can be looked at from a policy perspective.
And from a patient perspective, that's probably as important as what your dental benefits are, right?
That's right. Even more important, right? But we do have the star ratings, and I think a lot of people know this. So there are these star ratings. You can be from 1 to 5 stars, and the ones that have the higher star ratings, those plans get extra reimbursement. So they do look at certain things, but not denial rates. That's not one of the metrics that they use. But they do have other sort of quality assurance measures that are in there that are helpful. So if you've got a plan that's 2-star, you can look on the Plan Finder tool and see a little bit of the detail of why that's happening. So there does need to be more transparency in all of this, especially for the consumer.
Maybe you can add that to the 20-second pitch to the congressperson.
There you go.
Talk fast.
That's right.
Absolutely.
That's right.
Oh my goodness. I can't thank you enough for being here with us today.
Thanks, Gina. This is amazing. Thank you.
Thank you. Thank you. Thank you for what you all do and getting all these good interviews out there in the world. And it's a crazy world right now. So we have to do, as someone said to me, that if you focus, that's a way of getting through. And that's what we're trying to do here at Senior Pharmacist.
And hey, maybe, once we have a better idea of what the heck is actually going to go on with Medicare and our government next year, maybe we can do a follow-up podcast where you can continue to educate our audience and, get that knowledge out there that's ever so important and powerful.
Be happy to do it. Thank you so much.
Great.
All right, you guys, it was great doing this. Thanks everyone at home for listening in, and have a great Friday and happy weekend, everyone. Bye-bye.
Bye-bye.
Thanks, y'all.